Hello, my name is Pippa, and today I'm presenting identification, management and outcomes of acute kidney injury amongst emergency general surgery admissions at the Royal Devon and Exeter Hospital. Perioperative AKI in the elective general surgical population is of growing incidence and concern, being associated both with short and long-term morbidity, mortality and poor care processes. A recent confidential inquiry highlighted the lack of data relating to AKI in surgical admissions, despite a number of recent reports giving key recommendations for AKI management within this cohort, especially in those with coexisting frailty. So we performed a novel comprehensive review of all emergency general surgical admissions during January 2022 with these three defined aims. Overall, there were 559 emergency general surgical admissions, and of those, 45 were identified as having an AKI. We compared demographics and outcome data between those with and without AKI before further detailed analysis within that AKI group looking at key performance indicators. So what do we find? AKI occurred in 8.1% of our emergency surgical admissions, with the majority of those developed within 24 hours, although 29% were hospital acquired. Whilst the majority of AKIs were stage 1, we found 9 patients had an AKI stage 3, and 6 patients developed an AKI within that immediate post-op period, with a range of procedures performed, including 2 NELA patients. Overall, patients with AKI were older, with a mean age of 74 years old, and had an average of more than 10 days longer length of stay, with higher discharge mortality rates of 18% compared to 1%. With regards to AKI management, we found that fluid and medication reviews were more commonly performed, whereas urinalysis and blood gases were often omitted. And also, we identified that only half of that AKI group had this reported on their GP discharge summary, with even fewer having future recommendations. Overall, it's well established that surgical AKI patients have increased mortality and morbidity than medical AKI patients, and this project provides the most in-depth analysis of AKI amongst emergency general surgical patients in the UK to date. These poor outcomes are likely due to a combination of factors, including surgical insult and pathological process, such as ischemia and hypovolemia, therapeutic factors such as use of IV contrast and aminoglycosides, clinical factors such as backgrounds of CKD, and also we identified that key performance measures were often omitted or delayed, which may reflect poor real-time AKI recognition, instigation of management, and thus outcomes. The findings from this study will form the baseline results to design and implement a QI project to improve the recognition and management of AKI amongst emergency general surgical inpatients. This is particularly pertinent at the moment given the continuous increase in elderly frail patients presenting with acute surgical emergencies, both locally and also nationally. Thank you.